All right, everybody. My microphone, is it working?
Not working. Doug, not working.
It's still not. Testing. Test that microphone. Oh, don't tap. Sorry.
I don't know. Sorry.
We don't want to break.
Hello.
Hudson. All right. Welcome back, everyone.
My bad.
Hudson. So this will be our final session, or we'll still have a rounding out closing remarks afterwards, but this will be our final session to really dig a little more deeper on the topics that we discussed yesterday about from the orthotrauma standpoint, and particularly on wound infection prevention and control. It's well recognized, as we learned from discussions throughout the past 2 days, that the volume and complexity of injuries that are occurring in Ukraine are just staggering. These are occurring in a very typically resource austere or limited setting. The volume creates problems from the standpoint of there being the time to give proper treatment that would happen under normal conditions, and that's compounded by resource availability. Hailie, Uren here, talked about the issues related to antibiotic resistance because of the patchwork utilization of just what's happens to be available sometimes on the front lines, and some misconceptions about what is actual proper use. So we're going to continue on that today and try and maybe flesh out a little bit more of those topics and put them in perspective of what we've learned and what we can summarize and what we can take away from this whole summit on those issues. So we have as our esteemed panelists, again, Dr. Michael Samotowka, a surgeon from the United States and with Med Global, Dr. Hudson Berrey, a surgeon with a distinguished career both in the U.S. military but also in our some of our top academic facilities in the United States in ortho and trauma, and our friend Hailie Uren from Australia, who's our experts on infection and particularly some of the antibiotic issues. So just to start things off, maybe I think Hailie, you're the person to really take point on this, because you've been so focused on wound infections and have been operating, I think mainly in Lviv, based on what you said. And if you just want to expand on, set the stage for us.
So I've been working with Lviv Hospital.
Here, try this one.
I've been working with Lviv Hospital for a hospital in Lviv for I guess nearly 1.5 years now. And we have been looking specifically at the infected patients and what type of resources or what type of teams are in Ukraine who are looking and treating these infected patients. Approximately 90 to 100%, somewhere between that, of the war-wounded patients that are medevac to Lviv are infected. Not just contaminated, they don't just have dirty wounds, they are actually clinically infected. They have a temperature, their white blood cells are extremely high, procalcitonin is really high, and they are infected with extremely resistant bacteria. But it's not just the war wounded patients, it's all the civilians who come in as well. So we have, someone who comes in with pneumonia that generally the rest of the world gets treated with basic penicillin because it'll be tell me if this is too jargony, but a gram-positive organism, and they all have gram-negative bacteria. We have babies that are less than 7 days old with gram-negative multi-resistant bacteria. Pseudomonas that has absolutely no sensitivity to anything. Babies getting born fresh. It's an extreme problem. I can imagine that this is a problem in every hospital in Ukraine. So I think rather than me talk to you about what we've done in Lviv, I think there should be more collaboration or a discussion between the people that are here as to, do you experience this problem as well? And we can talk through some solutions or how to go about it to minimize this issue, because I know that everyone is really struggling with this. It's not resourced. We don't have all these NGOs coming to help with infections. There's no photo opportunities that the donors can have. The surgeons with the scalpel is very appealing to publish on Instagram or on their social media pages, but you can't take photos of patients with infections because a lot of the infections are coming from our hospitals. It doesn't look good, but we need to talk about it and we need to share ideas and come up with some strategies. So I think what I would like to do, and I know there are a few people here from Ukraine, I would really like to know where you're from. Are you working with the hospitals? Are you experiencing this problem? What are some strategies that you're doing? And are there any areas that you would like help with?
And if you wouldn't mind, just introduce yourself and give us a little just background, please.
First of all, good morning, or rather good afternoon. It's an important problem, indeed. Important, why? Because I'm a trauma orthopedist, and I am involved in the treating of the soldiers, and we see quite a lot of issues. That includes the problem with the following. A lot of wounded soldiers who had difficulties with evacuation, and there was inability to provide proper care at the battlefield or immediately after. And later, when step by step the logistics manages to take them to hospitals in the rear where specialized care can be provided, we see that we have patients with multi-resistant flora. 2 or more different pathogens, and not gram-positive or gram-negative flora, but both gram-positive and gram-negative. And it has almost no susceptibility at all. One of the options there is surgical, like multi-staged debridement, and I would like to ask for your opinion. What have you seen? What is the experience of treating these patients in the US, if you've seen them, and especially in the military medicine? How do you deal with this issue after conflicts in Iraq or other conflicts where the US were involved?
Test, okay. Use the microphone better. Hello? Excellent remarks. And as Dr. Samotowka has repeatedly preached, and I have shared the same message anywhere we go, the most important process for keeping an infection from happening is adequate initial surgery. And the question comes up is that what is being done on the frontline hospitals when the patients are first received from the stabilization point to the first time of their first operation? So my questions with the development of the infections is a number of possibilities. One is it inadequate surgery, inadequate initial surgery, and is that because of training? Okay, but now we're into the full-scale war 2.5 years, so I would hope that would be better. The second option is, are there resource constraints? So in our doctrine, what we categorize as a major wound would get 12 liters of fluid to wash out the wound. Not necessarily antibiotic solution or betadine, but just saline, high volumes, but low pressure. So, and the surgeon's index finger is the best debrider. And what I would used to do is I would wrap a sponge around my finger so I would have a little texture to it so I could, the third possibility is there a time constraint because of the number of casualties that are coming in at any one time? Then the fourth part on this is how much do each of these contribute? And then the fifth part is, soldiers who are on the front lines live in the dirt. They are completely dirty from the head down to their toes. One of the things that we found coming from Iraq and Afghanistan is that it's very important to make sure the entire patient is clean. They come in, their uniforms are cut off, they're cleaned from head to foot. We have a protocol for using chlorhexidine washcloths, disposable chlorhexidine washcloths. And so it takes 6 of these chlorhexidine washcloths to clean off a soldier. Okay. So we found that significantly reduced the risk of infection when they're going from Iraq, Afghanistan, back up to Germany. They cut down. Most of the infections that we've found are hospital acquired. They're from that patient, their own skin flora, or from other patients, because we don't exercise proper isolation procedures, hand washing, PPE, and it's not an issue of antibiotics. So when we actually get down to it now, we are practicing World War I medicine. So we didn't have antibiotics back then. So what would we do? We used a lot of Dakin solution, hypochlorite, which is one of my favorite things to use. And for me, for a patient that I had with a very bad wound, I take him back to the operating room every 48 hours to change their dressing, in the operating room. You can't. I've been through the ICU at another hospital full of very badly injured patients, and they're changing dressings on the floor under propofol. And these were patients that in my setting would be back in the operating room. 30-minute procedure, make sure it's all washed out and clean, repacked, and then, and this is a whole ward full of open beds, patients right next to each other, all with infections. And so it really isn't any real question as to why these infections are happening. The fact that we don't have, that everybody doesn't get infected is something. So the other aspect of this, which I think is very important, is that you really have a significantly delayed evacuation process from the front line to the stabilization point to the first line hospital, and then from that hospital farther to the rear. Their initial evacuation can be up to, I think Dr. Vesely said, 30 hours from the bed. You're automatically dealing with an infected wound at that time. It's heavily, the soil, and I don't, maybe Hailie has information. I suspect the soil just is loaded with antibiotic-resistant bacteria. So you're already behind the curve, and then with each evacuation, each transfer level, if you don't have a clean wound to start with, you're just going to, provide an environment for bacteria to flourish. One of the best media for bacteria is dead muscle. I had spoken with the woman who was very involved with putting together the evacuation railway, because they have ICU cars in their rail system, in the hospital trains. And I suggested that they need operating rooms on the train. So, well, that's kind of a crazy idea. But it's not for really technical surgery. It's for, the making sure the wounds are clean. So our ORs run 24/7. We start, first thing in the morning, and then we've got a whole list of patients that have to be washed out. And our day isn't done until each one of them has been through the operating room. And then we get up and do it the next day. It's exhausting. What I don't understand is that, there are a lot of doctors in Ukraine, but where are they in helping their country? And because the people on the front line are going to be exhausted. People need, and again, part of this is surgical training. And in my hospitals, and I've worked in lots of level 1 hospitals, we cannot teach residents, our trainees, how to debride war wounds because we don't have them. War wounds don't happen in the civilian setting, and that's the part. And maybe Michael can expand on that.
Yeah, thank you very much. So I agree with everything that you said. A couple of points to add. The best antibiotic is a proper debridement. And that involves removing any dead, necrotic, non-viable tissue, but it also involves removing any hematoma, because ultimately it's the hemoglobin, it's the blood that serves as food for bacteria and allows rapid progression of infection. In general, the washing out of a wound, as Dr. Berrey had stated, is high volume crystalloid fluid. Some people will use Dakin, some people will use betadine, some people use peroxide for foaming to remove pressure. The problem with all these agents is that they're caustic to normal healthy tissue, and they can potentially damage more tissue and make it non-viable. I think physically, with your fingers, remove all tree limbs, branches, fragments, any foreign body that you can. Wash the wound out thoroughly, clean it, make sure that you do have good hemostasis and that you're not going to develop a hematoma under the dressing. That's critical because that becomes a pool of food for the bacteria if there are any bacteria that are there. Cleaning the patient head to toe at the start is also critically important. I agree with that. And then apply a dressing. Now there's several companies, it's a multi-billion-dollar industry. There are several companies that make various products that they claim if you put on the wound will prevent the growth of bacteria. Some people will use Silvadene in a wet to dry dressing, which I've asked apparently is not available here in Ukraine, but one trauma surgeon that I worked with would make a slurry, take a liter of lactated ringers, a tub of Silvadene, which is what we use for burns, make kind of almost a mix, an oatmeal out of it, put it on the wound, and then dress the wounds. And that does work fairly effectively. But the other important thing is to treat the wound as a damage control situation and go back in a planned manner 12 hours or 6 hours, 12 hours, 24 hours later and re-examine the wound and wash it out, debride anything which blossomed out and became necrotic but was not necrotic at the first operation. Because again, the best antibiotic is a proper debridement. In choosing the antibiotics up front, if it's a simple grade 1 or grade 2 open fracture, ANSEF is probably all that you need. And I've got a pharmacist here and Dr. Berrey, so I'll ask for their comments here. But you don't need a broad spectrum antibiotic up front. That's going to get you into trouble. If it's a more serious contaminated wound, then you may increase the coverage. But if we've learned nothing else in critical care in America, less antibiotic is better. What we've done, if you look at the last 10 years of our antibiotic coverage, it's less and less. We used to do 14-day course of hospital-acquired pneumonia in the ICU. Now it's 5 to 7 days. For a simple open fracture, 1 dose or 1 day of antibiotics, and then you stop. Because the antibiotic is ultimately going to kill some bacteria, but what it will also do is breed out resistant bacteria. Now, when you have Pseudomonas as an infection, and it's multi-drug resistant, that is a huge problem, because Pseudomonas will eat proline suture. And so if a vascular surgeon has done an anastomosis, a bypass, or a shunt in the area to try and salvage tissue, the Pseudomonas will eat the proline and disrupt the anastomosis. The best treatment for that is actually Dakin's solution, bleach. Bleach, that's one of the indications for a Dakin's solution. There are 2 indications. One is a fungal infection, which for whatever reason Dakin seems to be very effective in wiping out, and Pseudomonas. Pseudomonas is actually a very weak bacteria. It only comes out when other bacteria have been suppressed in the field and wiped out by the broad spectrum antibiotics. So if you kill all the other bacteria, you leave a vacuum where the Pseudomonas can grow. Same principle for fungal infection. And that's again goes back to why we learned that less antibiotic is better. The more you use, the worse you're going to paint yourself into a corner. And for example, in talking to some of the surgeons here, they'll get a patient who in 7 days has had 8 different antibiotics. That's not good. What we need to do to change that is there has to be communication down the line from the start of when the patient was first seen by a clinician to the time that they arrive to whatever point of further care they're getting, what antibiotics were given, for how long, and what did the wound look like to begin with, and how much debridement needed to be done. There's no shame in going back to the operating room 2, 3, 4 times and re-debriding or re-washing out a wound until you truly get ahead of the infection, because the goal in the ICU is to reperfuse as much salvageable tissue as you can, stabilize the patient, and again, correct the triad of death, correct the hypothermia, correct the coagulopathy, correct the acidosis, and then go to the operating room, clean the wound, and when you see that all remaining tissue is viable and healthy, that's when you start discussing about further debridement and then creating a flap or a closure or or wound vac or whatever you want to do. Wound vacs, very popular, very nice to put on a wound, but the problem with the wound vac is as soon as you put that sponge on a wound and dress, you no longer see the wound, right? So if people are using wound vacs very often and they don't change the wound vac for 3, 4, 5 days, you really don't have a good appreciation for what's going on under that sponge. Those are my comments.
When we talk about less antibiotics is better, absolutely agree with one thing. What I notice a lot is underdosing when antibiotics are given. I would say, when I first started, all the patients coming in were on about half the recommended dose. So when antibiotics are getting used, they're getting underdosed and they're being used at the wrong frequency. So when we're seeing Ansef or Cefazolin, so many people are giving 500, 1 gram. That's not appropriate for an adult. When you're actually getting a patient into theater, 30 minutes to 1 hour before, 2 grams if they're over 50 kilos. I can't stress that enough. So with our traumatology unit in Lviv, we have increased the prophylaxis dose of Cefazolin. Always 2 grams. Try and get it within that 1 hour to 30 minutes before surgery. I know it's really hard. I know the coordination of getting that is difficult with shared responsibilities of who is supposed to give that dose. Another huge thing is when you have your patient and you see the wound, swabbing pus, that patient's come through maybe 3 hospitals, 4 hospitals. Swabbing the pus, that's not actually what they're infected by. Take bone samples, take tissue samples, send those to the lab. That's going to tell you what bacteria it is. For the patients, just quickly, one more, is that so many times IV is preferred over anything. Stop giving IV if they can be given oral. Stop giving IV pain relief when you have tablets. Every time you inject someone, the risk of introducing bacteria into that person, that's how some of the bacteria is getting spread as well. We need to be optimizing the use of oral medication much, much better. I know there's a huge culture of not trusting oral medication, but I don't see paracetamol or just ibuprofen tablets getting used. There's always IM injections. That IM then turns into a phlegmon under the skin. Then you have another infection that you're dealing with. Changing your catheters. They need to be changed more frequently and have a very sterile way of doing it. Your patients aren't washing themselves. They don't wash themselves. They don't flush the toilet properly. They have E. faecalis all over their skin. That's what's getting into these wounds a lot of the time as well. The patients are not sterile, and you have to encourage them, have showers a lot. I know they don't or they can't because they're in a lot of pain. Regular pain relief, making sure the patient's sterile, surgical washouts, that's the best option to prevent further infection, but there are still a lot of patients that are coming in with infections that are, may have been a wound and then they've traveled into the blood their pneumonia. All the patients at one stage getting evacuated on the train were coming with pneumonia. They didn't pick up pneumonia from a mine blast. They're picking that up from the other passengers on the train. So there are a lot of infections that you can't do surgery on, unfortunately, and they're really, really troubling, and that's the pneumonia and the urinary tract infections and whatnot, that's spreading between your patients. So essentially, if you use the right dose of antibiotic, you really minimize how many times you're perforating the skin barrier when you don't need to be. You're keeping your patient clean. On the frontline hospitals, appropriate debridement. I've seen 20 mils of saline being used to debride a wound. Not appropriate. I know that it's scary to use all these resources, but it needs to be done because we're losing a lot of lives. And for someone to have no infection when they're injured after just fighting for the country and them die because of an infection, of stuff that we can do to prevent it, it's not appropriate. We can be doing a lot better. And I speak almost as a Ukrainian because I've been living here, I'm a resident here for 2 years now. We have worked really hard on this in Lviv, and we have got the length of antibiotics down to, I think it's like 1.9 days, because the majority are just prophylaxis. And the patients are getting out of our hospital really, really fast now. So it's achievable.
Thank you for such comprehensive answer. A lot of what you shared is what we are already trying to do. Fortunately and thankfully to our armed forces, we are not a frontline hospital. We are a rare medical institution. And in the last 2 years, if I was to tell what we stopped doing, what we started doing, just like what Dr. Berrey said, washouts, washouts, washouts. The more washouts, the better. And I personally realized that the best antibiotic therapy for such patients is trauma orthopedics scalpel. So we are no longer using antibiotics as routine therapy, not until we have the results of microbiology tests. And we do not take microbiology swabs, rather we use biopsy of necrotized tissues, because that gives more accurate results. I have only one question left. In your opinion, what would be indications for wound wax?
I've used wound vacs a lot. I think there's a place for them. The problem that I see with the wound vac is that if it's just put on superficially, if it's a blast wound, and it's just put on superficially, then what you're doing, you're creating an anaerobic environment through all the different layers of muscle deep to that. So when I use a wound vac, I cut layers of it and make sure that it's placed everywhere that I can fit my hand. I put a piece of foam in there so that I'm making sure that I'm not creating a micro anaerobic environment someplace. So it has to be open. I have to and I use a lot of sponge. And again, you have to come back. The other problem I've seen with my own residents with this is that they want to leave the vacs in for for 3, 4, or 5 days. And at that point, you may have evacuation, which may be getting out fluid, but those bacteria are living happily on the muscle that's there for them in that environment. So it's an adjunct, it's not a replacement. I've been a big fan of Dakin solution. Washing, it's a hypochlorite bleach, dilute bleach solution. It was, originally used, I think, in World War I. And you wash wounds out with that, make sure that it gets in all the cavities, and then get your wet sponge and put it in again the nooks and crannies, the little places that you can stick your hand between in tissue planes. When you look at what effective a blast is or a bullet wound that's going through tissue, it has a lot of kinetic energy to it. So that zone of damage extends much farther than the actual physical wound. And I think this is part of the problem that we see with this. And it's very hard to teach a resident this, so that you have to take a little bit of the skin around. Save as much skin as you can. Skin is very important. But make a long incision. Make a big incision so that you can expose the entire wound. I think that's one of the big problems I see, is that, we don't like to make unnecessary incisions, but you have to have exposed. So what I tell my residents is that minimal incisions are for minimal surgeons. All right? Big surgeons make big incisions. And with war wounds, you have to make a big incision. You have to be able to open up and expand and look in and have access to all that tissue. And when you do that, you find out that there's much more injury than you realized. So when I was in Dallas, I was at the medical school in Dallas for a while, and I was presented with a patient who had this resistant infection. They could not get the patient been to the operating room a number of times, but the infection persisted. Now, the patient had been shot with a shotgun, okay? So as I said, you're the expert on infections, can you take care of this patient? I said, yeah, sure. That's what I do. I'm the last guy. There isn't anybody behind me to send a patient to. I'm the guy. So I made a big incision, opened it up, and what I found was the plastic wadding from the shotgun shell. So in the old days, there used to be a paper cartridge between, now it's plastic. That's what holds the separation between the charge and the pellets that go out. They had debrided everything they could see, but they weren't aggressive enough. So we see it everywhere. The one other aspect that I harp on for these patients, they're out in the field, they are dirty, and oftentimes they are underfed, they are malnourished, and then they become catabolic, all right? So you also have to focus on nutrition. Nutrition has to heal wounds. Nutrition is very important for wound healing. I think my surgical colleague would agree. Michael?
So let me just add to a couple of key points here that were made. Nobody's going to heal a wound unless they're nutritionally repleted. And basically what you're looking for in the intensive care unit is to convert the patient from what we call a catabolic state to an anabolic state. There are some surgeons now who will actually, put a nasogastric or nasoduodenal feeding tube in and will actually feed a patient through their operation and not stop tube feeds 12 hours before operation in general anesthetic. We're much, much more aggressive about enteral feeding, using the intestinal tract when you can to nutritionally support a patient. It prevents translocation of bacteria from the GI tract. It helps that conversion from catabolism to anabolism. It substantially makes a difference in the muscle breakdown. And so nutritional support is critical for these patients, proper nutritional support. If you cannot use the enteral tract, then we use TPN or some type of IV fluid. Just while I'm thinking about it, our pharmacist, Hailie, had spoken about IM shots. I don't know if anybody's ever had an IM shot, but it hurts. And if you have a patient in the ICU or critically ill patient, if you give them 6 or 10 IM shots over the course of a week, everything hurts. So you've increased their pain medication requirements, you get hematomas, you get a miserable life. So try to give everything orally or IV as you have to appropriately. The other thing that I want to comment about is the wound vacs. So the wound vacs were actually invented, I believe, at the Cleveland Clinic, where I worked for a while. And the wound vac, there's two principles. One mistake that I see residents doing is they shove as much sponge as they possibly can, which increases the wound size. You want to use adequate amount of sponge, but you also want the wound to start to contract down. And the other mistake that can be made is that all of the suction catheters have settings on them for how much suction. And typically, for an extremity wound, we'll use 125-100 millimeters of mercury pressure. To really create granulation tissue, you should use variable and not continuous suction on a wound. Because what happens is if you suck at 125 and then you take a few seconds off, or you drop to 75 and you alternate, that's what actually stimulates angiogenesis, and that's what stimulates the growth of granulation tissue into the wound. Because ultimately, when you take the wound vac down, if you see a healthy, beefy red granulation tissue base, that's a sign that that wound is not infected, because granulation, healthy tissue does not grow in an infected field. If you're constantly sucking on a wound through a wound vac at a consistent suction pressure, you're not really taking the maximum opportunity of how the wound vac was invented and created to function. What you want to do is suction on the wound to remove foreign debris and then release and go back and forth every few minutes. And what that does is it creates an environment that's clean and allows angiogenesis, new blood vessels, to grow into the wound and to form the granulation tissue which you want. So nutrition, critically ill. As aggressive as you possibly can be. Number 2, proper use of wound vacs. Wound vacs are great, but you can make your own wound vac if you want to. We call it a Bogota bag on the abdomen. Basically cover the intestine with serrated plastic, lay a saline-soaked gauze, and then another layer of plastic, and put 2 drains in, and suction on that. And then it's much cheaper than the wound vac with the that's made by KCI or whatever other company makes, Smith Nephew. You can change those, but leaving a wound covered under a wound vac for too long creates a problem, because you don't see what's happening underneath. It's not, some people kind of fall on it as well, that means I don't have to change the dressing as frequently. And that's a problem, because that's how you create an environment where bacteria can grow. Now, there are silver impregnated sponges now because silver impedes the growth of bacteria. Those are very expensive, and I'm not sure that there's much value to them. There's the blue sponge that you can put on, or the white sponge that you can put on bowel with just a thin layer of xeriform over it. There's the blue sponge that we use on the open abdomens. Now there's the purple sponge that you can actually put on an incision to suction out the effluent so that an incision stays clean. All of these are great, but they also, the wound vac has its limitations. If you're not using it properly, you may not be really maximally helping the patient.
Agreed. I would like to get Ms. Uren's thoughts on IV versus IM, and also the use of TPN.
So we're in a challenging situation in Ukraine. A lot of the gram-positive bacteria, we still have oral options available. So we have really good sensitivity for MRSA, for MSSA, for any other gram-positive to clindamycin. Clindamycin is really good because you can put them on IV whilst they're critical, but then after the CRP or procalcitonin comes down, and they're able to have oral medication, it's swap them over because the patients are getting infected from the constant lines that are going through their bodies. We have oral metronidazole. There's no reason. Metronidazole, I think, lasts in the body for about 36 hours, one dose. Like, you can be absolutely giving that orally. Doxycycline is oral. There's so many oral medications. It is very difficult for gram-negative. We don't have so many orals for gram-negative. We have Biceptol, or trimethoprim sulfamethoxazole, which still has really good sensitivity for gram-negatives. I say really good, I mean, the best thing that we've got. We have a lot of oral medications available, and they are approximately 10% of the cost. So one dose is, for IV, is well over 100 hryvnia. One tablet is 10 hryvnia. It's so economical, and it's safer for the patients, and they do work. So you can use oral medication once that patient is not in that critical state, and that's the case with any of the medications. Just try and give as much as oral as possible, and you'll be preventing further issues down the track. Nutrition and smoking. So patients, we know that there's a really high use of nicotine. We also know that constantly, it doesn't matter if someone's just lost their leg, they'll find a way outside the hospital to have a cigarette. And patients who may have had acute osteomyelitis, you're getting on top of it. If they start smoking again, the risk of them getting chronic osteomyelitis is so high. So you can't, having a conversation with the patient, not coming and standing at the bedside and just saying, having a look at the wound, but have motivational interviewing, saying, you know, you may lose this leg if you smoke. I'm sure it will be enough for them to cut down or at least stop the smoking, because a lot of the infections are happening in patients who smoke. It is a vasoconstrictor. The antibiotics aren't even getting to the area. People with diabetes as well. Really, really important that you spend time having conversations with them. It's really difficult for these patients to overcome infection, so you need some time to sit down and actually have a conversation where they are listening to you, and their stress of having a doctor at the end of their bed starts to lower by kind of coming down on their level, sitting next to them rather than having the hierarchy of standing at the end of the bed and saying, look, these are the changes you're going to have to make sure that you are going to survive, you're going to have your best chance of healing these infections. I can't stress enough about the lines. So your PIVCs, your urinary catheters, your intubation tubes, they're just absolute breeding grounds for bacteria. If the patient can urinate by themselves, they need to be urinating by themselves. Pull out those lines and make sure that they're getting regularly checked and regularly changed, because it's just introducing bacteria straight into the bloodstream. In Ukraine, the rate of, if someone has sepsis in Ukraine, the rate of the chance of them surviving is about 10 to 15%, which is not what is happening around the world. It's very, very severe here. Patients who have a bloodstream infection, there's a 50-50 chance that they'll survive. I would say about 80% of those patients are getting these infections from the lines that are going into their body. A big thing I want to talk about is also looking at deterioration of the patient. Often, I know how busy you are as surgeons. You have all these patients, you're in operating theatre. How are you working with your nursing staff to check your patients on a day-to-day basis? You maybe have 1 minute, 2 minutes a day that you can see your patient. Who's monitoring them for deterioration? I know nurses here, they're not documenting in the electronic medical systems. They may write down on the prescription what the blood pressure is, but a static blood pressure does not tell you anything about your patient. You really need to be encouraging your nurses to be taking blood pressure, to be taking pulse, the pulse, and also the respiratory rate. You need to know, I think time and time again, I see a patient's temperature on paper is perfect, and then they die. Why? Because that temperature is being taken after paracetamol is being given. Like, it's not a true reflection. In the ICU, the patient's blood pressure is getting controlled by medication. Their respiratory rate is getting controlled by ventilation. Their temperature is getting controlled by paracetamol. How are you looking? How are you checking if your patient's deteriorating because of these infections? So that's a big thing as well, is we need to be working more as a multidisciplinary team to be monitoring for signs of infection and working on preventing the infection when you do have the patient under your name in the hospital.
I would like to ask, what is your protocol when you have a patient comes in with a big wound? What is your protocol for that patient? How do you take care of that patient surgically, nutritionally, whatnot? Because the one thing my residents understand is nutrition is exceptionally important. So how often are you able to take your patients back to the operating room for those washouts?
Thank you for this question, and thank you for this once again very detailed information. I can briefly share my experience. It all depends on the patient, because I work in a civilian hospital, and our hospital provides care to both civilian patients and the military patients. If a civilian patient has a trauma, for example, an open fracture, like Anderson 1 or 2, what do? As fast as possible, on the day of admission, as fast as possible, we do the surgical debridement, and we do not prescribe antibiotics. We once again use the biopsy method, and we take the sample, send it to the microbiological examination. Usually it comes back in a few days. I mean, the result comes back in a few days. Then we wash the wound. We look at the wound, at the fracture, and if there are no signs of infection, we treat this wound as a clean wound. And then, correspondingly, all the operations are following the methods, and amongst them is the osteosynthesis. So if we see in a few days, and usually it's seen by the wound, by the fever of the patient, and locally we might see, or maybe the patient complains, so we see there's infection. And if there are changes in the blood panel, we understand that the wound is contaminated, and then as it comes after day 2, we already get information which antibiotic we must choose to prescribe depending on the type of pathogen we have in the wound. If the patient is a military, a serviceman, usually they come to us after having passed a few other hospitals, and very often the pathways are complicated and there are many difficult stories on this pathway. In 99% of these patients the wounds are contaminated, and in many patients they are full of pus and you don't even need to do a bacteriological examination. It's enough to smell and you understand that, well, it's a purulent wound. So on the day of admission we try to send the patients to the OR to do the debridement using, amongst others, antiseptic solutions to wash out. And once again, we use this biopsy to identify the pathogen. If it's multi-resistant flora, we are not using any antibiotic because, in my opinion, it just makes no sense. Maybe I'm wrong here, but why do we do the antibiotic when it's all RRR, all resistant in the panel? Like, none of the antibiotics we prescribe will not be effective. This is usually what we do. I love using wound vac, but in short cycles. On the average, it's about 3 days. There's a dressing, then I open the wound, and for at least 24 hours we are not using the vac therapy. It's only the dressing, because we want to look at the condition of the wound. Then 24 hours after, we may decide to either continue dressing or use something else to close the wound, or we can use a wound vac again. Antibiotics. We now have guidelines on antimicrobial stewardship, and now we have a ban to use IM antibiotics if there is any other form available. So if there's an IV form available, we must use the IV. If it's a pill, we can use a pill. And only if there's no alternative and only the intramuscular form is available and it's mentioned in the package insert, then we can use the antibiotics intramuscularly. This is actually a latest achievement of this year. We had these new guidelines, and it's good clinical practice. This is how we work.
You mentioned, do you take a biopsy or a culture at your first washout? Your first time you're taken to the patient to the operating room, do you take a culture at that point in time? Okay. That's something that we have not found to be very effective with being able to decide if there's going to be a wound infection and helping us decide with that. So I think our guidelines now are that to not do that, but just to have the patient, just wait until there's suspicion of an infection beforehand. And then when there is a suspicion of infection, at that point in time, take the culture. And the other point is that, especially for a wound that is weeks or months old, like you deal with, you may have polymicrobial environment. And so my practice has been to take multiple cultures, multiple tissue swabs from inside the bone, one end, the other end, taking it from muscle, in order to give the bacteriology lab, because what we know is that we underestimate the amount of contamination or bacteria, underestimate the number of bacteria that are involved in this infection. Mike, any thoughts?
Yeah, we don't culture the wounds at the first sitting. I think you have to, because it can give you misleading information. What you really want to do is find the proper bacteria that's causing the sepsis and target your therapy to that. So when there is a question or a concern of an infection is when we would culture the patient. The other point that I was thinking about as I was listening to the other speakers is removing central lines, removing Foley catheters whenever a patient can urinate on their own, getting any kind of foreign body out of the patient as quickly as possible is also very helpful, because you can get a urinary tract infection very easily from a Foley catheter that's been left in too long. So it's important on every day when you round on the patient to think about these other smaller, what seems to be peripheral and trivial things, but they're really not that trivial. Look at the IV sites, make sure that they're not infected, not red and swollen. Make sure that the Foley catheter has been removed if they don't need it anymore. Take drains out when they're appropriate and they're not having any high volume output anymore, and keep a close eye on the patient themselves.
I know with the military patients, I would say majority of them are infected, systemically infected by the time they come to a reconstructive or a major tertiary hospital. We know this because they're clinically very unwell. So I wanted to kind of talk about some strategies maybe as to what to do if we must, if the scalpel isn't enough and that patient is infected systemically. Because you're right, all the microbiology tests are coming back resistant. What we've found is that by combining some of the medications, we're optimizing synergy between a lot of the antibiotics and of very basic antibiotics, and we're able to cause the bacteria to be sensitive again. I want to also talk about and maybe ask if you have any experience with bacteriophages, because I know Ukraine has been using those for many, many years, but now it's getting taken very seriously in the world. And I know that some very big clinical trials are getting done, and it's something that I think will be really, really critical in such an environment of antimicrobial resistance in the future. And I think we should be striving towards getting involved in those trials in Ukraine, because our antibiotics most of the time aren't working, or they're very toxic for the patient. So many times we have patients come in, they're on polymyxin with amikacin, it's killing their kidneys, their ears, they're on maybe vancomycin as well. We need to be looking at different strategies of combining either safer drugs together which synergism is pretty much what we're using for majority of our clinically, systemically infected patients. I would say 9 times out of 10, monotherapy is not working. But I think looking towards different innovation or re-exploring bacteriophages is something for the future as well.
I think the one thing that can help you with dealing with infected patients is having somebody like Hailie. Okay? So in my working in Lviv, we got to know each other because I'm very interested in the treatment of chronic osteomyelitis. Devastating, you know. And I'll have patients sent to me with chronic osteomyelitis, and if they smoke, I'll tell them, go away, quit smoking, and then come on back and see me when you do. It's not worthwhile. It's not worth my time if their health is not important enough to them to quit smoking. But I think having people who understand the bacteriology and the antibiotics available is very important. There's so many different options, and I can't keep track of them. And I think I'm a smart guy, and I've been doing this a long time. So I need help. I need help. Plus, there's always new things that are coming down the pike. And, you know, they'll have the reps come in to see them, and they're actually very, very good at sorting out the good people and the bad people, all right? The people who are just selling you something, and the people who really have something to offer that can be positive. So in our hospitals, we have infection control doctors, we have infection control nurses, and we have clinical pharmacists. And it's all a team that I'm just a member of that team. I may be the captain of the ship, but I'm just one member of the team. I can operate on a patient. And by working as a team, everybody starts to understand what's important. And this is, I think, my value for teaching residents. I can teach anybody how to operate, almost anybody. But the one thing that I try to get across to patients is across to my residents and the medical students, is how to take care of patients. I'm not just a surgeon, all right? First, I'm a doctor. Second, I'm an orthopedist, okay, musculoskeletal. And the third on that list is a surgeon. But most of all, I'm a doctor, and I take care of patients, and they're my patients. But there's not enough of me to learn everything that needs to be done to get those patients better. That's why it's such an important part of taking care of patients is having a good team, putting together a good team with that.
I agree, and it's very easy to work as a team when you're all communicating together, and your patient will get quicker a lot faster. In 2021, the Ministry of Health order that you were talking about, Order 1614, said to every single hospital in Ukraine, you must have a functioning infection prevention control and antimicrobial stewardship. Within 6 months, the full-scale invasion happened. The thought of allocating all these resources to building up IPC and antimicrobial stewardship, I understand, very overwhelming, and it's not where the resources were best used then. It's also very impossible to implement a program based on a paper order. Ministry of Health may say, okay, you now need this, but how? How are you supposed to do it? It's really, really hard, but if your hospital executives, if they are motivated to do it and you do it, your patients will survive more. They'll leave the hospital faster. It'll save them 50 times what it costs to implement these programs, more, 100 times. It's really, really critical. It's very new in Ukraine. I know with IPC, it's getting led a lot by epidemiologists, and they have maybe 3 people for 1,000 beds. They don't have the time to be to be teaching people, to be doing surveillance. They're just constantly doing reports for the Ministry of Health to fulfill all the order guidelines. But it needs to be very practical. It needs to be those people working with the treating teams and coming together and having conciliums about what to do. Like, I can't stress enough about how effective multidisciplinary conciliums are. We use them a lot, and you get a really good perspective from not just the anesthesiologist and the orthopedic surgeon or a general surgeon, but having someone who can then come in from a different perspective of optimizing other treatments as well. That's been really, really, really helpful to us. And then we have this shared sense of trust that you can bounce ideas off one another. An example of this is we had a patient with acute osteomyelitis, and I had a really good relationship with the surgeon looking after this patient. Generally, osteomyelitis, we know it takes about 6 to 8 weeks of antibiotics. If your patient is on 6 to 8 weeks of IV antibiotics, and we don't have outreach services that can go to the homes of the patient, we know the patient will be in that bed for 6 to 8 weeks. If you need to do that, that patient will very, very highly likely pick up another infection in some way. They'll have a fall. There will be a big problem is pressure injuries in the beds. That's the type of thing that will happen. So if you have a good relationship with clinical pharmacy or someone who knows about infections, after 2 weeks you can drop down to oral antibiotics. That patient is mobilizing. You're preventing a lot of other hospital-acquired complications. So I can't stress enough, if you are having conversations with the hospital administrators, or you are a hospital administrator, to start building up these teams, because it's the hospital-acquired complications that are causing significant morbidity and mortality of the patients.
I'd like to open up. Are there any other questions or any other thoughts? Yes, sir.
Good afternoon. My name is Oleg Panasenko. I'm a surgeon and also a president of Free Trade Union of medics. Many of our colleagues are providing medical assistance in civilian hospitals, and also they're helping our servicemen on the front line. I have a question. Do you know about the book of Wojno Yasenecki, articles on contaminated surgery, something like that? Wojno Yasenecki?
I'm not familiar with that book or that author.
Да. Да. Я хочу тоді розповісти про неї. Ця книга дуже допомагала в часи Другої світової війни зцілювати
This book was instrumental during World War II for treating the wounded, and it was republished in 2006. And I have a Russian name of the book to share with you, and I encourage you to read it. It's a brilliant book, and today we heard that sometimes there's just no broad access to antibiotics. So this book is about that in particular. In World War II, there was limited access to it. The book is called Sketches of Purulent Surgery. I hope this will help both Ukrainian and NATO military. Luke Voyno-Yasenetsky, Sketches of Purulent Surgery. And by the way, I believe that this book is available at the library of the Lviv Medical University. So I think you can look it up there.
Thank you. And, I do believe there was someone from our online
May I make a
participation.
comment?
Oh, sorry, Hudson, go ahead.
I think your point is very well made. And as I mentioned once, we're almost back to World War I types of surgery. So we have to keep things, we have to do mechanical cleaning and make the environment good, use dressings. We use a lot of Dakin solution, which came out of World War I, or other kind of dress. There's a lot of money being put into what the best option is for doing that. I don't know, they have lots, they do clinical trials and whatnot, tell you that with a small clinical trial this works, but I'm not sure, I don't know. I'm a simple man, I like simple solutions, and so that's what works best for me.
But you're not a minimal surgeon because you make big incisions.
Yes, that's a great point. We are returning to the methods of the World War I and World War II. So that actually emphasizes my point about this book, Sketches of Purulent Surgery, because it's brilliant.
Perfect. And yes, do we have the online participant?
Hi, yes, thank you so much. This is Roxana Horbavet. I just wanted to make two comments. This was a great discussion. I appreciate everyone's comments. And my comments are, one, is to take a look at the training that is done during wound packing. So at ground zero in a way, or close to it. If you watch that and in multiple videos, and then not only the training, but also the care that's given, you'll often find that the wounds are nicely rinsed with what looks like at least clean water, sterile water probably, and there may be some material around the wound in order to protect it. But then you see dressings typically being taken out of the sterile package and allowed to just drop onto a dirty surface and then being dragged across into the wound as the packing is packed. And unfortunately, I think we don't often realize that when we are doing training on models, that we're not emphasizing enough to maintain clean technique. And so that's something that I think might help in minimizing the contamination of the wound when it's very fresh. And so what's being taught more so now, but probably hasn't penetrated maybe enough, is to keep the dressing in its packaging and to slowly just pull it out as you're packing so it doesn't touch anything really before it gets into the wound. So that is one thing that potentially may be able to help. The second thing about vacs are really great devices. However, they do have specific indications for use and conditions of use, which includes the duration of how long a sponge would be in a given wound. And that depends not only on the type of wound that you have, but also the type of sponge that you have, because there are some sponges that are silver impregnated. There are some sponges that are impregnated with other materials. And so I very much encourage everyone to go back to the instructions for use. I've put the link in the chat, as well as pictures of the indications for continuous versus intermittent use. They're very clearly spelled out in the instructions for use, and also the a type of dressing and the type of wound that is suggested. So I just wanted to share that because and for some wounds, the dressing should be in with some sponges no longer than a day to two, because we know that the sponge then becomes contaminated and a source of contamination. We also know that you're not supposed to leave dead spaces in a wound. The space should be filled. And so I encourage that. Thank you so much. Very interesting. And the third thing is, I believe that the speaker from Ukraine, not the last one, but the one before, when he talked about biopsying a wound, he wasn't talking about swabbing or superficial tissue cultures. He, as what I understood, said that they don't do that because that wouldn't make clinical sense to them. But what they were doing was taking deep tissue samples in order to get the assessment of bacteria. So thank you so much.
Thank you very much for those. Thank you very much for those comments. And I'll start with the last comment first about the swabs versus biopsy. I believe in tissue biopsies, but I have been to the operating room many times. I have changed dressings many times with my colleagues, and I see swabs being done. And I think they are often inadequate. The VAC subject is important. They can be misused, and I agree with that. As far as the packing material, I would always leave, if I have a roller gauze or a Curlix, I would leave it in its package, and if it needed to be saline soaked, I would have the soaked in that. But this is, again, a part of training and retraining, and this is one of the primary roles of an infection control team, of making sure that the method in which dressings are being done in the cleanest way possible. This is an infection control nurse teaching other nurses how to ensure as best possible sterility of the material that you're using. Comments, Mike, Hailie?
So we do multidisciplinary rounds every day with a pharmacist, the bedside nurse, the physician, and the team, so that everybody's on the same page and knows what's going on. I think that's very important. I do think it's critically important to have a clinical pharmacist on board to properly dose the medications, and also to review the medications periodically and see what no longer is necessary and what can be dropped off. Less is better if you can do that, and also the adjustment of the analgesics. But looking specifically at the wounds and culturing the wounds, once a culture is grown, you try to choose the antibiotic that is the least broad spectrum, that will effectively treat the correct bacteria that you've identified. And again, we try to use it for the least amount of time absolutely necessary, so that we're not breeding out the resistant bacteria. But I do think there's a lot of importance to having a clinical pharmacist helping to guide the choice of drugs. I mean, I can just think about, since I finished medical school, how many new antibiotics, how many new medications have come out. It's impossible to keep track of all of those. So we do rely heavily on our clinical pharmacists for that.
Talking about wound dressings, So I have seen across Ukraine single-use or packaged dressings aren't really being used so much, realistically. Ideally, yes, you would be taking a dressing out of a package and using that sterile dressing immediately. In reality, it's not happening. What's happening is these big bulk Costco-size dressings are being handled, they're being cut, then they're getting sent to sterilization, then they're coming back from sterilization and getting put into this communal drum and then getting used. So how can we, in Ukraine, rather than use this process, which is a recipe for disaster, how can we encourage or find these single-use items to change dressings? Because it's not ideal, and at the moment they have a list of inventory that they're able to order. Generally, they look at what they've done for the last year and just reorder it. We need to put a line in the sand and say together, we're not going to do this anymore. We're going to move to single-use items that come out of a package and are completely sterile and don't require getting sent and handled by multiple people in the line of moving them from a surgical department through the transport person to the sterilization unit to back to getting put into a drum where they're all mixed in together. How can we draw a line in the sand and move away from that practice? Because we can say all these really good ideas, but we need to think about how we can change the system here, because it's very difficult, and it's for someone who is, I know that hours get spent cutting these dressings, and it's really, for me, nurses are the best people to be working with the patients. They're the ones who know the patients the most because they're at the bedside caring for the patients, washing the patients, giving the patients medication. In general, if you ask who knows most about the patient, firstly it's the patient, the family, but then it's the nurse. So how can we get them away from being tied up with things like paperwork and cutting dressings and re-sterilizing things that should be sterile in the first place? And how do we shift the culture?
That's Nobel Prize work. I don't know. I mean, I would ask our Ukrainian colleagues, how do we change the culture for taking care of these wounds on the floor? Big question. I don't have the answer to that. But anyway, Doug?
Do I have the answer?
Yeah. You got an answer for everything.
Yeah, the radiologist in the room is the one that you're going to ask the question about antibiotics, right?
Turn off the lights, you'll come up with an answer.
I'll come. This is your I'm not going to use the your dazzle them with your brilliant or with your because I would be doing the other one. But at this point, we've got, just from a moderating standpoint, about 20 minutes or so left. Is anyone else in the audience or online that would like to address the panel?
Can I just make one more comment then, Doug?
No.
To the last topic that we had. I think one of the really nice things about Med Global and David Knott Foundation is that both have now started having an education track trying to elevate the profession of nursing. And that's critically important. In where I practice, the nurses really do a tremendous amount of work. And I think that culturally, getting to what Hudson was speaking about, it's a big difference what you see in Ukraine. And I do think that that change has to happen, however it happens, that we really do need to elevate the respect and the responsibility of the bedside nurses and the operating room nurses, nursing in general as a profession. And that's something that we can help bring to the table in all these collaborations.
I think it's important for the doctors, the physicians, the surgeons to be the champions for the nurses. All right? We have to show them respect and make sure they get the respect that they deserve. So once you give them some pride and some respect, that they see that you respect what they do, that will spread like wildfire. And I think this is something that you can work with your other doctor colleagues about, because I know historically, from what I have been told by people who have much more experience with the system than I have, that it's very hierarchical. You have a chief, and he sits right next to God, all right? And you don't question God, and you certainly don't question the chief. So it's important that people are questions, all right? That you ask, so that you can't be afraid of questions. People, that's why being in education and being around smart residents and smart medical students makes you smarter. That's what keeps you young. It keeps you motivated. And certainly there is more than enough work to be done in this world than one person can do, we as physicians. It's reliant on us to create the environment where we can bring everybody up. And when you do that, the downstream benefit of it is that your stature with your colleagues is going to increase. If they know that you have their back, that you support them, they will work that much harder to make sure that the work gets done and your patients get the best care. If you speak down to nurses, if you speak down to the techs, speak down to the pharmacists, like that, they will do the minimum that needs to be done to make sure that the orders get taken care of. But the system won't flourish. And that's really what you want. A vibrant, working should be fun. Working should be fun. And when you work together, when everybody has a shared common goal, you create a team, then especially, the most important part is then your patients get the best care possible, because everybody's contributing. You may not always agree, and disagreements are fine too, because then they help stimulate the thoughts of, well, why are we disagreeing? What's the best evidence out there to answer this question? And I'm the first to admit when I'm wrong. I don't know the answer. This is what I thought I knew, but I'm an old guy, okay? I went to medical school 50 years ago. And, the questions have all stayed the same. Just the answers are different now, all right? And I don't know those answers. So people tell me the answers, and that's why that's one of the ways you can stay current, and that's why it's important. There's all sorts of innovations that come along, and we have to be ready for them. We have to be open to them. We have to be able to recognize the ones that really have no value. It's just, a quick buck scheme. And then there are those that are real bad. But the problem is trying to be able to tease out between the two of them. And as Forrest Gump says, that's all I have to say about that.
Somehow I doubt that's all you have to say about that. Well, thank you to our panel. I think maybe at this point we should maybe, I think I can surmise some of the key topics and then maybe see what might have been left out. Because I think just starting at the beginning, that's a good place to start. Clean, 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 clean. Debride, 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 debride. That's important. And the best two tools, I think, Hudson, you said the finger of the surgeon, maybe plus or minus a sponge, and irrigation. And copious irrigation is very, very important. High volume, low pressure. I think, as Mike pointed out, non-toxic, non-irritating irrigants as are available and possible, but in certain conditions, some higher level forms of irrigation like Dakins, particularly if there's some specific indications like fungal, and I think you said Pseudomonas are the two. After proper irrigation has been done, which needs to be done early and frequently, follow-up washout and debridement should occur, and whenever possible in the OR with anesthesia if necessary, and not at the bedside. When, as is almost inevitable, infection does occur, the proper antibiotics should be selected and should be dosed correctly. They should, if possible, be oral whenever they can be, and not IV. On the issue of the use of wound vacs, these can be very valuable in certain settings, but there are some significant drawbacks because once the wound vac is placed, the wound is invisible, and that requires that they be changed and monitored carefully. And as was brought up by both Michael and Dr. Roxanne online, that in certain cases there may be value to using impregnated sponges with those wound vacs. However, from a cost perspective, that could be detrimental or just not feasible. Another issue. I thought you were done. I thought you had nothing else to say. But wait. Okay.
And I can't believe that Hailie didn't mention this. One of the things you should know is what the common bacteria are in your hospital and what they're sensitive to. This is something called an antibiogram. And with that introduction, I'll turn it back to Hailie.
So every single patient that has a microbiology test, every single result needs to be collected over about a year, and then you get a beautiful table of all the bacteria and all the sensitivity. You then know what antibiotic to use. When your patient is deteriorating, it gives you an educated guess as to what to give them that will have the maximum chance of them getting some clinical response from your antibiotics as quickly as possible. It's really time consuming, but this information you need. You cannot develop empiric guidelines without this information. You can't know what antibiotics you give a patient who's septic. You can't wait for a blood test to come back for a septic patient. You need to be giving them something as soon as possible, a combination of medication. There are times where you absolutely cannot wait for that microbiology test before you start treating with antibiotics. And you don't know what to use unless you have collected the information from every single patient for a year, from all the bacteria, to know what to use. So it takes a team, and I have a team who worked with me on this to collect this information. It is absolutely critical to do for your hospital by itself. You can't do it for a whole Ukraine because Ukraine is a big place. You need to collect this information for your hospital because antibiotics at times do need to be used before a microbiology test comes back. So it's absolutely essential that this information is collected.
And what she didn't say was that this is an ongoing project. It's not just a one-time deal, because bacteria sensitivities may change over time. So this is information that is updated on a regular basis, usually quarterly or semi-annually, but you have to keep up with this information and be able to get it out to your doctors so that in that situation where your patient is deteriorating and you know it's a gram-negative, it's a Pseudomonas, but you don't know which Pseudomonas it is or what it's going to be sensitive to, you can kind of figure out where it is or maybe what the combination of antibiotics could be to best serve that. And that's, again, where the clinical pharmacist comes in.
Yeah. So, again, just to find other holes that Hudson has more things to say about. So, with the wound vac issue, again, we said there are some caveats we need to be careful about. The wound was no longer visible if it wasn't properly cleaned and debrided. And one of the things that Michael really emphasized with proper cleaning is that includes getting rid of all the hematomas and making sure there's hemostasis, because that will be a source of flourishing for the bacterial sources. If the wound isn't properly closed, it becomes an anaerobic paradise, as Dr. Hudson Berrey pointed out. And again, as Dr. Hudson Berrey pointed out, minimal incisions are for minimal surgeons. So for war wounds, we need big incisions. You need to be able to properly evaluate the wound and your debridement, because you never know when a plastic wad from a shotgun shell might be hidden away. To close that out, when you are thinking of secondary issues, removing lines and tubes as early as possible as potential sources of infection outside of the wound itself and the wound contamination itself are important. And then in the larger setting, nutrition and behavioral issues such as smoking are also enormous factors for wound care, infection, and how the patient will do. Hudson brought up, particularly with chronic osteomyelitis, smoking is a particularly bad issue. And then overall, even in the best of circumstances, a lot of patients are going to get sick, a lot of patients will deteriorate, and as Hailie has informed us, up to 15% of those patients with sepsis are going to die, and so you need good... 80. So, or maybe it was 10 to 15%. Yeah, okay. And then, so there needs to be strategies in place to optimize for that. And those strategies include when the patients become resistant to antibiotics, use some of the strategies that Hailie had mentioned that might increase sensitivity is, again, bacteriophage strategies is one of the things we talked. And as Hudson said, you have to have a good team. That team involves nurses, because they're going to be the ones seeing the patients most frequently. They're going to know them the best. We have to empower our teams, and that includes nurses, techs, our fellow physicians. We need to tear down the hierarchies that prevent the proper questions from being asked. And Hudson, what did I leave out?
One of the things that I've observed is that we have patients with infections in big rooms where patients have clean wounds. And and it may not be possible to practice, isolation. So you have an infected patient in our hospital. They have a private room. They have proper protective clothing outside. You have to mask up. You have to go. So all those conditions are in place in order to keep that infection from spreading to anywhere else. That's hard in Ukraine because the hospitals aren't made that way. So, and because I do a lot of infection work, I had a part of a floor that was for my patients. So It wasn't necessarily for them, but it was to keep all the clean patients away from them. And so that's another aspect. There has to be some patient control, so you're not mixing up clean patients with dirty patients on there. So you're minimizing the cross-contamination of those patients.
And I did leave one thing out, Hudson, you didn't catch. Part of that great team has to be the pharmacist. So, Mike, anything to?
Nope, I have nothing more to contribute.
Okay. We are just slightly ahead on time, so.
I'll just say one thing is that it's very difficult to challenge the status quo. But it's really important now when you have so many international people supporting you, having your back with trying new things, that you question everything you're doing and say, should we do it like this? Don't just do it because it's how it's always been done. Challenge everything you do and strive to think how it can be done better.
With that in mind, what we're doing as part of this, and the room isn't very big, isn't very full right now. We've got some people online, but we're building an online community, okay? So when we go home, if there are questions, if there are issues to bring up, and you need support to make a change, we're there to help back you up. We're there to help with advice. We can, and that's the power that this technology, WhatsApp, brings to this. You know, we don't want all the work that has gone into putting this conference on to die here. We want this to be a birthing process so that we raise the community, and then you can tell your colleagues about this as well. We're not about keeping this quiet. This is just for ourselves. This is for as many people as we can reach as possible. And so I'm not, as I said, I'm technologically challenged, but I will turn it over to our moderator to further expound on this.
Thank you, Hudson. To expound upon that, I'll go back to where we started this conference with our statement of purpose. And our statement of purpose was that we came here all today, many of us traveling from across the globe, to stand in solidarity with our friends and partners in Ukraine, and that our goals and objective there were to share and learn from one another. And on that means change the paradigms, share and challenge the paradigms. Change is hard. And being that agent of change, you oftentimes don't get thanked for that. It's usually sometimes quite the opposite. But to purpose point number 2, we came here to build partnerships, and that means that moving on from today, we're not done with the discussion. These discussions should continue. And then to number 3, we hopefully built some friendships here, and that will extend and foster our ability to really build out those partnerships. And then 4th, and I think this is something that's really important to I'm sure everyone who's Ukrainian in the room, but to those of us who really know and love Ukraine, we're here to honor Ukraine. So with that, was there anything? Okay, so we have just a couple minutes left, so we'll keep these brief, but we have a couple more from the audience.
I just wanted to say thank you to everybody for this amazing interaction. Based upon the hospitals that I've worked with where infection control is an issue, I think the content of this session has been incredibly valuable, and we need to find a way to share it. So my question is, I assume you have a recording of this session. Could we arrange to get it put on YouTube and share the link in the WhatsApp group so everyone can spread the word with their Ukrainian colleagues? I'm sure if we get Ukrainian subtitles done, even better, because then everyone in Ukraine can use this, every surgeon, every medical doctor in the army, and get value from it. The value is immense. That's it.
Simple answer is yes. I'll keep it
Thank
simple.
you.
Talk. And there, I think, was one person online. Again, we have our closing session coming up, so we'll want to keep this brief, but we want to make sure everybody gets a chance to participate.
Hi, yes, thank you very much. I just wanted to mention about contamination. I greatly support the surveillance of hospitals or medical facilities, but I also just wanted to remind that, and Dr. Hudson may remember this, when the conflicts erupted in Iraq, we were faced here in the US with soldiers coming back with very, very resistant infections. And we found later that the infections stemmed actually from bacteria that were in sand that we hadn't been familiar with. And I imagine that that occurs in every environment. And so some of these resistant bacteria may actually, as I think someone may have mentioned, be from the soil or the environment that they contact at the point of injury or transport along rough roads. Many of them are carried or dragged many kilometers. So that's a source of infections. Thank you so much. I agree. It was a great session. So thank you.
All right. Well, again, thank you, everyone. We've got maybe 1 or 2 minutes if anybody needs to brief everyone out, but then we'll reconvene here at 4:30 and close out our second International Health Summit in Kiev. So thank you, everyone. And